What's going on, everybody? My name's Adel, sports neurologist at the UCLA Brain Sport Program. And today, I got a very special guest, Dr. Kevin Bickart, attending neurologist, sports neurologist at the UCLA Brain Sport Program. And you've got a lot of interesting stuff going on, right? We're going to be talking about a lot of really, really cool stuff today. It's going to be a really great episode. We're going to be talking about a lot of these objective measures for concussion that are on the horizon, right? That seem to be the future of concussion, both diagnosis and management. Would you agree with that?
Yeah, I think there's a lot to talk about. We'll just scratch the surface on some interesting topics and see where it takes us.
As we mentioned, we're talking about these sort of objective measures for concussion that are on the horizon, right?
Yep.
You're interested in the autonomic nervous system after concussion. So obviously coming up with an objective measure to be able to measure autonomic dysfunction after concussion,
Yep.
which I think is not really very much talked about, especially with the contribution of autonomic dysfunction to people's concussion symptoms,
Yeah.
right? And even persistent symptoms beyond that sort of 1 month period when we say that a concussion usually resolves, right?
Right.
And then you're also interested in fMRIs, right? Which we get a lot of people asking us a bunch of questions about functional MRI for good reason, because it's an awesome, really, really cool field that I personally think is probably gonna revolutionize concussion care and as well as concussion diagnosis and even traumatic brain injury care and diagnosis too.
Yeah.
And then, we'll talk about if we have those objective measures and those diagnostic measures, then potentially we can institute therapeutics, really cool therapeutic stuff to be able to target the things that we find wrong on that objective measure and diagnosis, right?
Exactly.
So take it from here. Autonomic dysfunction and concussion.
Yeah. So, I think the big picture is if you took a 30,000-foot view, you need something objective in concussion because up to date, it's been thought of as this kind of elusive condition where you can't find anything objectively wrong. If you look in the brain on brain imaging of all types of modalities, you look on the skin surface to look for some electrical impulse that suggests there's something wrong, and it's really just kind of difficult to find some solid abnormalities that are universally thought to be abnormal. If I took one person after a concussion and looked at their numbers and tried to compare that to norms in the general population, it might not find anything abnormal.
Right.
And so therefore, how do we diagnose concussion based on quantitative data other than asking them their symptoms subjectively? Or how do we determine who is going to go on to have chronic symptoms after concussion? The rare few that do go on to have chronic symptoms would benefit from knowing that early on so we can deploy more resources to them and potentially even target those resources to a specific dysfunction that they have related to their concussion. And so ultimately, the field would benefit greatly from having a set of biomarkers, a set of quantitative variables that you could collect from the skin surface, like from echocardiogram or electrocardiogram, or from electrical impulses that reach, the wrist, and you can collect it from an Apple Watch or some other kind of wearable device, or the finger from an Oura ring or something like that, where you can actually start to understand how the physiology changes acutely and then chronically in someone who's had a concussion and may go on to have chronic symptoms. So that's kind of the gold standard. That's what we're all trying to do, is figure out who's going to have chronic symptoms and what resources do you deploy to them? How can you target treatments to prevent chronification of symptoms, or at least alleviate those symptoms once they've become chronic? And so the world of biomarkers in general in concussion is is really getting exciting, and there's a lot more interest in it. But as far as autonomics go, I think the gold standard of autonomics is really the EKG, the electrocardiogram, to look at electrodes around the chest to figure out how the heart rate and the variability between beats is affected by any particular condition, including concussion.
Right. Now, the way that relates, the way that your heart rate relates to your autonomic dysfunction is because heart rate is controlled by the autonomic nervous system, right? So we have two parts of the autonomic nervous system: sympathetic, parasympathetic. Most people probably know that, right? Parasympathetic, in simple terms, slows down the heart. Sympathetic increases the heart rate, right?
Yep.
And that would kind of translate with, these objective findings of what your heart rate is doing on an EKG or anything else that would measure sort of your heart rhythm, right?
Yep. Yeah, exactly. And the idea behind looking at heart rate and other metrics from the EKG is to see what is the balance between the parasympathetic and sympathetic nervous system, or arms of the peripheral nervous system. And so if you could figure out that balance and then figure out if that is equal to a normative sample of people around the same age, around the same fitness level, and determine whether that concussed individual is outside that norm, that could be a really simple, very fast, very standard test to do in anybody who's had a concussion in the acute or chronic phase. Now, it doesn't work out perfectly in the data yet that doing a simple ECG or EKG and looking at heart rate or other metrics like heart rate variability can diagnose someone with a concussion. But in the more chronic stages, it's found across several studies, 15 to 18 studies, that there's an abnormality in the parasympathetic arm, that the ability for the heart rate to be dynamically controlled, to slow down when there's not a lot of demands, to kind of speed up or kind of pull the foot off the brake and allow the heart rate to speed up to dynamically handle the demands of the situation, whether it's a physical demand or emotional demand, the stress of a test or something like that. The heart rate needs to be variable to be able to increase blood flow to particular areas, and then decrease rate when that's over, and somewhat immediately. And so the parasympathetic arm is in charge of that kind of management of the space between beats, to slow it down and to speed it up. And if it's really dynamic, that tends to predict a plethora of positive outcomes across the population at all ages, right, from better emotion regulation ability to better fitness, longevity, better kind of resistance against the common cold, things like that. So it's a marker of health in many ways.
Now, the EKG, is that a dynamic objective measure of the parasympathetic nervous system or our autonomic system working right? Or do you think that EKG isn't sufficient to be able to kind of measure that dynamic sort of autonomic response?
Well, I think it's a great index. There's lots of ways to gauge the autonomic system, whether it's parasympathetic or sympathetic, and the EKG is kind of the gold standard. It's not wearable per se. You don't go around kind of tacking an EKG on, right, and walking around, at home and things like that. It's possible, and there are monitors to do that. It's just not that comfortable. But nowadays, there's even more wearable devices that are smaller, that are using other sensing modalities like PPG or photoplethysmography, like in a little ring or a watch, right, where it's got lights that shoot through the skin, and then it can pick up oxygenated blood flow and get the rhythm of the oxygenated blood flow becoming oxygenated and deoxygenated, right, oxygenated, and that gets at the rate. Every time the heart beats, more oxygenated blood comes, right, to that area of the skin, and so it can then dynamically figure out the heart rate and the space between beats. And if the resolution is good enough, it can give you an accurate version of heart rate variability. And really, that seems to be one of the most diagnostic and interesting measures of the autonomic nervous system, kind of leaning towards more the parasympathetic arm.
So heart rate variability.
Yep.
There's a lot of talk about that, right? You see that term thrown around a lot. Can you just break it down for us?
Yeah. So, in general, the heart has a mechanism where it will contract and push blood throughout the body and lungs, and it does that. Could be 60 times a second, 60 times a minute, for example, and that would be kind of a heart rate of 60. But there's space between every one of those beats where the heart can fill and get all the blood to then pump back out, and that space between is kind of the variable component. So the space can sometimes be several hundred milliseconds, and sometimes can be even 1 second, right, or more. And so as that space between successive beats varies, you can measure that as heart rate variability, the variance or the variability between successive beats of the heart. And the more variable, the better. And what determines that is the parasympathetic tone, or the degree to which the parasympathetic nervous system has control and is functioning optimally to vary the heart rate, especially during resting conditions.
Right.
Once you get into physical exertions, the parasympathetic nervous system will start to pull away from its control, and the sympathetic nervous system will take over. And so the heart rate variability doesn't become as meaningful there. But in resting conditions, it's extremely meaningful. It's exciting. It's possible to measure from all different points of the body, not just from an ECG, but like I was saying, from light sensors on wearable devices. And that makes it possible to consider this as a variable you could put, if you got the wearable, you could put it on somebody, send them home, check in with them weekly after a concussion, and see how those heart rate variability numbers change over time.
Right. So outside of heart rate variability, are there any other objective measures that have got you excited that measure our autonomic nervous system?
So there's a ton at BrainSport that is being done or being used, and most of them are in the experimental phase, and a lot of them are more clinically based, user-friendly for a research assistant or a clinician to deploy in a clinic visit, such as pupillometry, where they'll shine a light into the pupil and see how quickly it constricts,
Right.
and then how quickly it relaxes after that light shines in. And that could be a measure of both sympathetic and parasympathetic tone, just another gateway into that side of the autonomic nervous system. And then there's also looking at the amount of carbon dioxide that you are exchanging, and again is another kind of look into the autonomic nervous system. And so that involves kind of nasal cannulas and a little device to measure the gas content of what you're breathing in and out. But also has some exciting new results, not as user friendly, and definitely not kind of a wearable device that
Right.
one could take home with them. And then things like taking heart rate and heart rate variability and blood pressure and looking at how that is changes with exertional or positional changes. And so the kind of classic assessment of the autonomic nervous system is an orthostatic challenge. And so
Right.
going from laying for some period of time, like 2 to 5 minutes, and then standing for some period of time, like 5 to 10 minutes, and watching how the blood pressure and heart rate accommodate to those changes in gravitational demands. That tells you kind of how the autonomic system is primed to dynamically change with the demands of the situation.
Right.
And so those people who respond normally will often respond normally in other situations outside the lab.
Right.
But those people who don't, and say have a big drop in blood pressure or a massive acceleration in heart rate, when the demand is really not calling for that,
Right.
that is kind of an exaggerated and dysfunctional response, which is a cue that outside of that circumstance and other demanding and stressful situations, the autonomic nervous system might be over-accommodating or exaggerated, causing things like fainting or feeling lightheaded,
Right.
feeling foggy, not having enough blood flow to the head, and things like that.
So, because let's explain what happens, what the autonomic nervous system does when you stand up, right? So, basically, when you stand up, your blood pulls down to the bottom because of gravity, right? And then your sympathetic nervous system goes into effect, squeezes your blood vessels, and maintains that blood pressure up to your brain, right? That's what happens regularly. And then if you feel lightheaded upon standing, then potentially that means that that sympathetic nervous system response to be able to do that might be hindered, right?
Exactly.
Now, that brings me to my next point in regards to sort of these postural changes. What about POTS, postural orthostatic tachycardia syndrome, right? So I think that's a big contribution, and I think they've been finding a lot that, especially after concussion, we have a lot of people that, have lightheadedness upon standing and some other sort of dizziness symptoms associated with their overall concussion symptoms that are likely contributing to their concussion, their post-concussion symptoms. They come in, we diagnose them with POTS. Right. And it seems like the diagnosis of POTS is rooted in an autonomic nervous system dysfunction.
Right.
Is that right?
Yeah.
And I think I saw a study where, they brought in, I think it was about 35 people 35 people. I think they were all having lightheaded symptoms after their concussion. And then, they did a tilt table test, right? Which is basically you lay on a table, right? And then they tilt the table and then they measure your blood pressure and your heart rate after tilting and changing your position, right?
Right.
And then I think they found, I think in about half or a substantial amount had POTS. And then they coordinated their severity level, their post-concussion severity level, the symptom severity level after their concussion. And they noted that these people that were diagnosed with POTS had a more severe post-concussion symptom severity level, right? Which is interesting because that means, hey, if we got people coming in that have had concussion that are lightheaded, right? At least a screener for POTS, right, is probably appropriate.
Yeah, I think it's an interesting overlap. I think potentially more interesting is that people with POTS tend to have symptoms that overlap with post-concussive symptoms. And so even if the patients with post-concussive symptoms never had POTS or the patients with POTS never had concussions, their symptom complex tends to overlap in the form of dizziness, lightheadedness, headache, brain fog, fatigue. All of those symptoms are on the checklist, and in some cases, the diagnostic criteria for those two seemingly separate conditions.
Right.
And so one is kind of forced to draw some mechanistic explanation for why that might be the case. And so if you try to connect those two conditions to a nervous system explanation, common nervous system insult like the autonomic nervous system, that would make a lot of sense. And we know in concussion that patients tend to have, at least some proportion of patients tend to have autonomic dysfunction, as I was just saying, with poor heart rate variability measurements. And so it's not inconceivable to think that concussions could affect the autonomic nervous system directly.
Right.
And maybe that's why some patients that we're seeing with persistent post-concussive symptoms also have diagnostic criteria for POTS.
Right.
And so there might be a mechanistic link. And so it's really kind of a valuable insight that I think is born out of some kind of clinical experience, seeing both conditions in a clinic over time, that you then can bring to the lab to try to quantify what is the percentage of patients who've had a concussion that have postural orthostatic tachycardia.
Right.
And if you treat the POTS, do the post-concussive symptoms get better?
Right.
And so that's one gateway into what we call endophenotypes,
Right.
or kind of specific clusters of symptoms and biological signs like tachycardia or elevated heart rate upon standing, to then target treatment towards a group of patients. It might not be all concussive patients develop, an orthostatic tachycardia or any other autonomic dysfunction, but some that do may benefit from this type of treatment.
Hence, my advocacy for screening for POTS for post-concussion symptoms of post-concussive patients that have lightheadedness, right? If it's as simple, because how do you diagnose POTS, right? Like as a screener at least, right? You measure blood pressure and heart rate when you're lying, and then you measure blood pressure and heart rate when you're standing, right? So as a screener, that's like so simple, right?
Yeah.
So that's one thing that I advocate for. And then what I didn't mention as part of that study is that they measured basically brought back the POTS patients and then measured their blood pressure and heart rate again. And then a lot of them kind of did not meet the diagnostic criteria for POTS anymore, right? And then they also noticed that in those patients that no longer met the diagnostic criteria for POTS, their post-concussion symptom severity score was a lot lower than the ones that still had the diagnosis of POTS after they diagnosed them later. So, all right, let's move on. What do you think of cerebrovascular reactivity?
So it's not my area of expertise, but it's kind of inherently linked to the autonomic nervous system, and it's kind of bringing the autonomic nervous system insult that may occur with concussion in link to cerebral blood flow, or the amount of blood that the brain sees per beat or over a minute's time. And that's kind of very tightly controlled by the autonomic nervous system and several other factors that would be a really nice mechanistic link between autonomic dysfunction after concussion and brain fog
Oh, it
or
would be
cognitive
great.
symptoms.
It would be a perfect explanation for it. And I was going to talk about that, but go ahead.
No, it's just there's plenty of studies now that are looking into that, and Dr. Perkayasta's group actually has many studies. Maybe we can link them to the podcast that look at cerebral reactivity and other forms of blood flow studies using MRI to determine whether there's this kind of signature difference in post-concussive patients as compared to patients who've not had a concussion.
Are you talking about the one that just came out in 2020? I was actually looking at that one where it was, I think it was an enhanced bold fMRI cerebrovascular reactivity signal acutely, and then one that was decreased subacutely, and that kind of correlated with their persistent post-concussion symptoms. Is that the one you're talking about? I don't know.
I don't know
We'll put it up.
the findings off the top of my head.
It'll go up on the screen somewhere. Over you. Superimposed over
sounds
you.
good.
Or me. Yeah, go ahead. Anything else regarding CVR?
We have some data to that effect, which I think we're plugging through and will be very interesting because you can get at this brings up the point about biomarkers and kind of how you can efficiently collect these in a time frame that would make sense to, one, diagnose a concussion, and two, prognose whether someone's going to go on to have post-concussive symptoms in a chronic phase, post 1 month, 2-3 months afterwards. And so there's a study that went on at UCLA over the last several years that collected data on athletes from the surrounding area who had concussions, and then matched athletes in the same sport who didn't have concussions, and then athletes same age, kind of same demographic, but outside a combat sport, something like cross country and things like that, and looked at the brains both with cerebral reactivity as measured by ultrasound, going through the skull, looking at blood vessels that kind of go out into the brain and then loop up and give blood flow to the whole brain. The velocity of that blood flow tells you how tight those blood vessels are and how dynamic they're controlled. And so looking from an ultrasound at the speed of blood flow in the major arteries that go up to the sides of the brain, you can tell something about the reactivity. And so just by ultrasound, it's not a wearable device. You can't go home with this thing, but it's not a very expensive MRI. It's a simple ultrasound tool that now companies are starting to develop so that you can operate it from kind of the level of a research assistant or potentially a medical assistant in a clinic.
It could be used on the sideline, right? It doesn't necessarily have to be a wearable. It can be used on the sideline.
Yeah. I think down the line, once we figure out if this is a good diagnostic marker in the acute period, whether deploying something like that can be done, by a training staff member on the sideline.
So now I think we need a transition to describe who cares about autonomic dysfunction in concussion? Like, how would that contribute to someone's concussion symptoms? From instead of just, you get lightheaded, so it's contributing, like from a physiological role, how do you think it could? And we kind of alluded that to cerebrovascular reactivity, right? Because it's important, because what happens in a concussion is, you have this microstructural injury to the brain, this big dump of neurotransmitters, right? Particularly glutamate. And then you have what we call like a neurovascular decoupling, right? Meaning you have a decreased blood flow to the brain in the context of when you have a high metabolic activity in the brain. And that is believed to sort of give you those post-concussion symptoms, right? So from a cerebrovascular reactivity standpoint, that's why I was like so pumped about CVR, right? It's because, well, that makes sense, right? You can't, especially when you work out or something like that, and you got to increase that blood flow to your brain. If you're not really able to do that due to autonomic dysfunction, right? And that clinically manifests as exercise intolerance, right? When you do exercise, when you're thinking, right? When you're doing cognitive work, and you have these post-concussion symptoms, and it's difficult to explain. Could it be explained by autonomic dysfunction leading to decreased cerebral blood flow? In the context of a high metabolic activity in your brain. I don't know.
Yeah. So I think that's one idea, is that autonomic dysfunction causes a change in cerebral reactivity, which causes a change in cerebral blood flow, which causes some cognitive symptoms. That's one mechanistic hypothesis. But then the other things are to think about are, does the change in autonomic function actually relate to an injury to central autonomic structures, not the brainstem structures that are in charge of kind of autonomic output to the periphery, like the heart and lungs and blood vessels, like we talked about, but the structures in the brain that actually can control the output from the brainstem.
Right.
And so the hypothalamus is one that many people might be aware of, but there are regions, quote unquote, higher order than that kind of house information and kind of control information flow with things like goals and fears and worries. And those regions also connect through the hypothalamus to the brainstem and can modulate autonomic function. And
which then would tie in these sort of anxiety-related disorders that some people either develop after a concussion or traumatic brain injury or are exacerbated following a traumatic brain injury or concussion, right?
Well, that's the idea, is to think about, hypothesize, and then test whether that's the case. I think it's reasonable to consider that patients with anxiety after concussion could be suffering from some autonomic dysfunction, whether that's because of a central cause to some of these structures I just was talking about, or peripherally.
Right.
And then in either case, when thinking about the autonomic nervous system, more of as an index that something's going wrong above,
Right.
Rather than the autonomic nervous system causing
all
this. I think it's probably both, but I like to think of it as an index that something's going wrong from above that's not dynamically controlling both arms of the autonomic nervous system.
But that doesn't explain everything then. I need one thing to explain everything, right? Like, I don't need that, but I think that's what everyone wants, right? That's what everyone...
But every concussive patient is different, and that's the challenging thing for patients and for the physician, but also for scientists, because every concussion really is pretty unique. It happens in a very unique person.
Right.
It can happen to anybody. It's not like it afflicts people who have some genetic predisposition to concussion. That's not what's happening.
Right.
And therefore, each person could be coming into a concussion with different past medical history, maybe a learning disability or psychiatric diagnoses, or poor coping skills or something like that sets them up to have a challenging recovery period. And then in the recovery period, it's different for everybody. Maybe they got advice from their doctor to rest for the next month and not go out, not go on their cell phones, not do anything, and lock themselves in a dark room, the so-called cocoon therapy, which is no longer recommended. And that would exacerbate things, causing kind of this increased sensitivity to the elements, the things that people are supposed to expose themselves to. And so everybody with a concussion is different. And then the mechanism of the actual injury is different. Some are more severe than others. Some occur due to a head hit to the front. Some occur due to whiplash injury and torsional forces on the brain. And some people have, stronger symptoms immediately after that really knock them out and make them have setbacks in the first week or 2 weeks after their injury, when they're trying to study or get back into their, Zoom classes or whatever it is, or back onto the field. And so all of that makes every concussive patient different.
Right.
And therefore, having a single mechanism, a single answer for why somebody has prolonged symptoms is just not going to cut it for concussion.